third is the winner. So I'll try to go fast on the first couple of slides now. So we as GI doctors are not very picky. We treat multiple organs from the mouth to the rectum, including liver and pancreas, and we deal with multiple data types and decisions. So the GI specialty is perfect for multimodal and multi-step reasoning. We do endoscopies, we administer therapy for several chronic disease. We perform radiology examination or even analyze pathology slides during endoscopy real time. And of course, there is an important economical impact on digestive disease, because you have to think that these are the latest data from the CDC. In 2010, between 60 and 70 million people were affected by all type of digestive diseases. And there was an healthcare cost impact on the US healthcare system around $141 billion. So you can see how much money is poured into this specialty. When you think about a typical journey of a patient with digestive disease, it's all embedded into exams, as I've said, of different modalities, several laboratory tests, imaging, both radiology and endoscopy, prescription and medication. So each time the physician has to check a patient with one or more digestive issues, he or she has to navigate across all this type of information in order to draft the correct diagnosis or management plan. So you can see that the potential of LLMs in this specialty for diagnosis and management, for interpretation of laboratory values, and for interpretation of multiple images sources, and of course to coordinate among all these type of data sources. When I began working on this research area 2 years ago in my previous lab, we started doing a systematic review. So we tried to understand what was the performance of LLMs when applied to digestive disease Q&A pairs. And we found out that the performance varies a lot across tasks and across models. So you can see there is a broad range of accuracy ranging from 6 to 91%. And the accuracy is not only task dependent, but also model dependent, because, for example, a smaller model like GPT 3.5 had overall accuracy less than 50%. And with the model increased to GPT-4, the studies and researchers were able to reach accuracy in the 90%. Of notice, the studies that reported accuracy over 75% were all studies that try to implement the first RAG strategy in the settings of digestive disease. And also, when we first approached this research space, much of the generative AI in medicine literature leaned toward the triple H principle, in which generative AI tools have to be helpful, honest, and harmless. And it was a useful North Star, but it didn't tell us how to operationalize safety at the bedside. And so the question was, how can we make Gen AI system to abide the 3H rule and make them more accurate and safer for patients? So, of course, we explored different strategies from prompt engineering to more complex one like retrieval-augmented generation and supervised fine-tuning. And now let's start exploring the potentials of some of these strategies. So I'll be talking about our results on RAG, supervised fine-tuning, and benchmarking of these models. When we started, the general strategy that other groups used was to implement somehow medical guidelines into a RAG system. And what they did, they took the guideline, run through an automatic PDF to text converter, and fed that output into a vector database to run a RAG-based system. We did the same, but unfortunately, the performance on very specific GI Q&As or patient clinical scenario was underwhelming, so it was very low. Therefore, we ran a kind of sensitivity analysis by designing questions that targeted different parts of the guideline. Specifically, we drafted questions aimed at knowledge contained in the plain text versus knowledge embedded into graphical elements. And you have to keep in mind that medical guidelines are full of graphical elements, including like flowcharts or graphical tables, and sometimes they include the most crucial information to treat patient. And we wanted to understand if any part of the document was not appropriately understood by LLMs. And the result was that when we queried information contained into the graphical elements, the performance was suboptimal. So there was some issues on how the LLMs were parsing or understanding the graphical elements. This happened because in the automatic conversion at the moment of the study, which was 2024, they also include a lot of junk text included in the PDFs or in the guidelines, and there is no actual accurate conversion of flowcharts or graphical tables into text. And also the LLMs were not provided any instruction on how to read a clinical guidelines, which is also important. So you can see that if there is an error somehow in the pre-processing part, this error may be perturbed furtherly into the RAG system. So we bind the response to a partially wrong context. So we had to fix this somehow. And this led to the first paper that we published on NPJ Digital Medicine, and I'm proud that it was one of the top 10 most cited paper in 2024. Where we designed an ablation study to evaluate the most LLM-friendly version of medical guidelines. So we started from converting the guidelines PDF into text using baseline automated converter. Then we did some text cleaning, so we removed all the non-informative data. Then we reformatted the text in a way that each section was preceded by some form of instruction. So we know that, for example, what was the title of a paragraph, what were the recommendation, or what part of the text contained evidence. Then we did on automated conversion from table into list. So all the graphical elements were converted into pure text. And finally, we provided instructions to the model on how to read the text. So what is the title, what are the recommendations, what they mean, what is the level of evidence, and what does the evidence mean when the recommendations are made. And in the last step, we also added a few short examples, introducing 55 Q&A example to align the model to our desired outputs. As you can see from this chart, the performance stayed below 60% up to experiment 2, so when the graphical elements were not provided as text. And when we proceeded to convert everything into a text and then do the medical evaluation by 3 human readers, the accuracy reached and overpassed 90%. So you can see that it's not that the LLMs probably don't understand the guidelines, but it's how we provide the guidelines to the LLM that may reduce or create some errors. All these tests were done on a particular topic of hepatologies, which is hepatitis C infection. And despite me, Dennis, and the other evaluator being gastroenterologists, we were far from being acclaimed as expert of this disease. So we needed a concrete external validation. And we called the expert from Europe. So these are the people who actually wrote the hepatitis C guidelines. And we asked those people to serve as evaluators of the model to validate what we did. And fortunately, they agreed to participate in the study. So we, of course, focused on hepatitis C virus infection. We tested the model GPT-4o. We had the European guidelines author to serve as evaluators. And we also asked them to design 15 questions and 25 clinical cases. And also we asked them to generate their free text answer for each of the case. And we used this knowledge as the ground truth. We tested the impact also of multiple chunking strategy. And we tested the impact of hyperparameters, in particular temperature and top P, on text-to-text similarity. As you can see here, we had three chunking strategy based on sentence, based on fixed length, the red one, and the purple, the violet one, based on the paragraph. As you can see on top of the graph, the similarity keeps to be higher when you do a chunking at the paragraph base. So based on the minimum amount of information that you provide the LLM, the similarity to the expert responses remain higher. And when you do like fixed length chunking or sentence-based chunking, the type of information you provide to the LLM is reduced. So also the interpretation of the medical text. We also tested temperature and top P from 0 to 2 for temperature, from 0 to 1 for top P. And what we found out is that for temperature, the similarity remains the same up to 0.8. Then I would say it starts to degrade a little bit between 0.8 and 1.2, and then drops from 1.2. Similarly, for top P, we found out that up to a top P equals to 0.5, similarity remains stable, and then started to degrade as well. So we tested also how many chunks to retrieve. We tested fine-tuning on the guidelines, and we asked all the guideline authors to evaluate the responses across two items, accuracy and clarity. Regarding accuracy, we did a two-way of grading, one by having a scalar point base scale, so we had a 10-point scale, and also a binary evaluation, so 0 1s. Interestingly, before showing you the results of the grading, I want to highlight that when we used a 10-point scale, the agreement, so the intra-class correlation coefficient between all of the graders was much higher when compared to a binary grading. So this is important because when we do evaluation of LLMs, we need to take this into consideration because we may have a lower agreement even between word expert on a topic on the same response. Regarding the human evaluation, so we had these four settings, and as you can see, the responses provided by the baseline model were way worse compared to the RAG system, where we retrieved 10 chunks of text using the paragraph-based chunking. On a scale to 0 to 10, for the RAG top 10, on average, the grader provided a 9.45 score. And based on the binary evaluation of accuracy in grade and clarity, the guidelines author provided 91.7% of scoring. And this was much higher than the baseline model, which ranged across 36.6 and 46.6 for accuracy and clarity. Then, of course, we also turned to a public benchmark to see whether we could reproduce our findings. And unlike general medicine, where there are well-known benchmarks, there is not a specialized and widely adopted benchmark for hepatology. So we leveraged one produced by the European Association for the Study of the Liver. And this association, beyond the simple multiple choice questions, it also provides us the performance of the participant physician test taker. So and more importantly, we aimed to evaluate not just one topic, but to extend it across all guidelines and all topics contained in hepatology. As you can see, the setting where we combine supervised fine-tuning and RAG, that drastically outperformed the human physician test takers, where the average human physician score was 56.9. The combined system achieved almost 90% of accuracy on this public benchmark. Of course, when doing all these studies, we need medical doctors to evaluate the gradings, and the problem is that grading is a burden for us doctors. So what happens right now is that we have, of course, several LLMs. Grading is time consuming, and the selection of the best LLM for specific use cases is extensively human labor intensive. So how can we reduce the time of grading? These are some of the results of a paper also published in NPJ. So starting on the top, left to the right, what we did is that we generated multiple answers from the same model. And then we compared them to the golden labels. What were the golden labels? They were free text answers from word experts, so the main authors of the what we call upper gastrointestinal bleeding across the whole world. So we had the main expert in the world giving us their answers on how they would respond to these questions. And we tested three different similarity metrics technique. The TF-EDF, the sentence transformer, and we also fine-tuned Colbert. And then we measured the similarity score of each QA pairs and ranked models across three different data sets. Importantly, these three data sets that were generated from a medical society by us and also by real-world questions asked during the simulation scenario, we had to grade more than 10K answers. So how did we fine-tune Colbert? We created substantially, we built triplets. We had the expert response, the M, which was the guideline test, used as a positive, and the N as a hard negative. Hard negative was a text similar to the guideline, but had minor tweaks that made it wrong. And we pass the pairs to the BERT encoder and train the model to increase the cosine E&M, so the cosine similarity between the expert response and the guideline text, and to reduce the cosine similarity between the expert response and the hard negative. What we found out is that we could rank multiple models. We tried 27 different model configurations. And when we compared the scoring by an automated system like Colbert fine-tuned on the word expert responses, we achieved grading that across all three data sets, which had a correlation between 81% and 91% to the human graders. But when we tested the other systems, the similarity remained below like 60% or for TF-EDF less than 40%. And the last part of my talk, I want to focus on the implementation problem. So we did several tests. So we found out that LLMs, if embedded with clinical guidance, they can be accurate. We may have found out a system that can be reproduced in other fields to have an automated way of grading, which is not just LLM grading the answers. The problem is that how do we create an environment which is safe enough that we can deploy the system and let physicians use it and test it and have a feel on how it works before risking the real patient harm. And we found a solution, developing one of the first randomized control trial related to LLM adoption into clinical healthcare using the Yale Simulation Center. This paper is very recent. It was published a couple of months ago. So what we did is we designed a platform. This platform was consisting of three different LLMs. We had the first LLM that you can see as marked in 1, which was a parser LLM. So when a new query appeared to the model, it decided to route it to an embedded machine learning model to serve as an interpretable AI tool, or to parse it to the guidelines. So each time a new query was created, we could query the model about the risk for the patient, but at the same time, we could query the LLMs. And the final answer produced by this 3 LLM system was based on the query classification and interaction of one of the two systems. So the model, or the machine learning model, or the medical guidelines. In the trial, we had two main arms. One was the dashboard arm, which only contained the model prediction dashboard, and the second arms contained the dashboard plus what we call GutGPT, which was the LLMs embedded in GPT-4o. And we asked physicians and medical students to undergo a pre-survey before and after starting the study using the UTAUT, which is a unified, which is referring to a unified theory of acceptance and technology framework, which has been widely applied to study health, IT, and clinical decision support system adoption. So what we found out at the end of the study is that the arm where the machine learning model was embedded with the large language model, users told us that it was easier to use. And even if we didn't find a difference in accuracy among clinical decision between the two, we also found out that users found out to be the LLM system to be more trustable compared to the other. And we also found out that the people who benefited more from the model and the system were medical students compared to attendings or residents, where probably they had more knowledge and so they needed to query the model less compared to the medical students. And to finish the talk, I want to highlight some point of what's happening right now in generative AI, especially in digestive diseases, but also other fields, is that I want to highlight that baseline models have a high risk of misinformation, but at the same time, we can integrate medical guidelines and medical knowledge using RAG or supervised fine-tuning, and both increase accuracy of the responses. Another problem is that we don't have benchmarks by medical society, so we don't know how to test them, even if we can create benchmarks from hospitals, so local benchmark, but we don't know how to test it broadly across different medical specialties. And at the same time, some medical specialty, like the European Association for the Study of the Liver, for which I'm a proud member and I serve on the AI task force, is starting to release some benchmark dataset that then we can use for testing. Another problem that we have right now is that we need a medical expert to grade all the answers. Unfortunately, we are very busy and grading is, of course, time consuming, but we can find some way to automate the grading. And there are several issues when we try to transport the system at the bedside, especially for safety and trust from physician. However, university with simulation centers can act as the first deployment environment for clinically oriented large language models. And one of the biggest issues right now is that, especially in this field, there is no robust study that has evaluated the impact of vision models. And as I told you, we have multiple image sources and we don't have data, or especially multi-agent systems. So especially in digestive disease, the field is still, I think, at the beginning, but I hope to see more results in the near future. And a great thank you to all the people who has worked with me in the past 2.5 years. And all these people have contributed some way to the work I presented today. So thank you to them, and thank you to all of you for welcoming me very recently. Thank you.